Good evening. Welcome to the second in our series of BOFAS webinars aimed specifically at registrars. This evening, we're going to be talking about ankle fractures. And ankle fracture fixation has always been our bread and butter. Indeed, the bimalleolar ankle fracture was always considered the training ground for orthopaedic registrars. However, how to manage an ankle fracture has always been based on a mixture of experience, tradition, and myth. So tonight, BOFAS Education Committee has chosen this evening's topic and this evening's speakers for their relevance to the topic and for the experience of the speakers, who have both been on a quest to apply science to start to define what makes an ankle fracture unstable. So tonight we're going to talk specifically in two areas, the posterior malleolus fracture and the syndesmosis. Our distinguished speakers are Andy Molloy, Senior Foot and Ankle Consultant and Honorary Senior Clinical Lecturer at the University of Liverpool, and Professor Lyndon Mason, who has been awarded the Hunterian Professorship this year for his distinguished work. Both have prepared concise summaries of about 15 minutes on their topics, and then we'll take some questions from you guys, and feel free to submit your questions on the toolbar below. We'll filter those and we'll spend some time asking these to Andy and Lyndon. And then we'll move on to a more of a fireside discussion where we'll talk through some foot and ankle cases and look at why the decisions are made in handling these ankle fractures. So without any further ado, I'd like to welcome from Liverpool, Andy Molloy.
Thanks, Rick. Sorry, apologies. My daughter's printing off some homework, which she's just been doing with a tutor. Right, I'd like to present to you our work on the evolution of posterior malleolar fracture classification systems and treatment algorithms. For this, there are huge amounts of acknowledgements for Anish Kadakia in Chicago, to the anatomists at the University of Liverpool, as well as the registrars and core trainees who've been through our departments and helped with the large amounts of research that's gone into this. So I'm going to go through the background, the science behind treatment strategies, the classification system that we came up with, the treatment algorithm that came through this, and what our eventual outcomes were. So I'll start with a bit of background on the first work that we did on ankle fractures. So back in 2011, really, it was starting to feel as if we were having to revise quite a few ankle fractures. So we did a prospective audit looking at this. And actually, disappointingly, what we found is that there was a 33% malreduction rate with an overall complication rate of 9%. Now, obviously, this was far from ideal, so we went through the typical scenario that happens in departments as we went through a period of re-education, which used things like audit and induction and such like. So after this period of re-education, we then re-audited in a prospective fashion. And unfortunately, this showed that there was a malreduction rate had actually deteriorated. So it was 44% with a higher percentage of overall complications. Now, it was only afterwards that we realised through further reading is when we looked into the basis of education and the psychological aspects behind it, is that education through emphasising negative points is doomed to failure. And actually, Cialdini's work on this showed that it's normalization of poor behavior. So what was actually necessary was overall system change. Now, these were numerous. So they included specialist foot and ankle clinics, specialist foot and ankle trauma lists, ease of referral patterns, and us being happy to take any of the fractures that people didn't feel as if they wanted to fix themselves. Now, as you can see from the results that we had from this, it was a great difference is the malreduction rate went down to 3%, and this 3% was actually understandable for how complex the fractures were, and there was a very low overall complication rate. So when I first presented the first two audits, both nationally and internationally, is that there was criticism leveled to me, maybe it's just that your department isn't very good, you're just doing it badly. Now, we actually implored people to go and check through their own results, and actually this is what happened, and there were multiple presentations from eminent departments which showed almost pretty exactly the same results. So I think this really goes to show that it's necessary that we all check our results going forward. So leading on from this, we wrote up our results together with Leicester. Now, what we found is if you took all fractures and split them into fracture types and did OMAS scores on them, is that by far and away the worst, and this was statistically significant, were the B3 fractures. Now, these are the posterior malleolar fractures, and they are significantly worse. So we felt as if that might be an area in which we could make some great improvement. So back when I was revising for my exam, certainly we were taught that if it's less than a third, don't fix it, just not necessary. So part of the basis of a lot of our research is taking things which are said to be true and held in regard that that is the definite way of doing it, and going back and checking the references, actually seeing whether it is true. So if you follow the rabbit hole down through lots of cross-referencing to find out where the original reference for this is, it's from that well-known orthopaedic journal, the Journal of Surgery, Gynecology and Obstetrics from 1940, where they looked at a whole 9 cases, which I think would agree isn't a good starting point for a treatment basis. So even going up to 2011, opinions hadn't changed that much. Is that if it was 50%, everyone would do, but if it was 20%, only 44% of respondents would actually go ahead and fix that. So if we back up just a little, what is a third anyway? So there's actually a whole plethora of literature out there which says that radiographs are unreliable at looking at the posterior malleolar fractures. So one paper showing that the diagnostic accuracy was only 22%. Others showing that CT changed surgical management in a large percentage of cases. The fracture fragment, which is far worse visualized, are the posteromedial fractures, which are extremely difficult to visualize. So if we just take some examples here we can see that there's a small slither off the back, and that's actually correct. But the reason that's correct is because the X-ray beam is going through the fracture site. If we go to this next example, is that you can see there's a potential of a small step there, but it's difficult to see. And this is a 2A fracture with a large posterolateral fracture, which involves articular surface, but because the X-ray beam isn't going through it, is that you cannot see it accurately. If we go to this third example, we can see that there's one big chunk off the back. However, when we CT this, yes, there is a big chunk off the back here, that with the X-ray beam going through, but the large posteromedial fragment cannot be visualized on this. So for a final example, we can see that there's an oblique lateral malleolar fracture, and it looks to maybe be a fragment there, but there's not much else on the lateral. But this is actually a really severe ring avulsion fracture of the ankle, with pretty much all ligaments disrupted. And if one obviously just fixed the lateral malleolus on this, is that you would still end up with a grossly unstable ankle. And this is the CT which backs this up. So we now CT all posterior malleolar fractures, and I would implore you to do this, and it doesn't matter how small a flake that it looks on the lateral radiographs. So the original classification was done by Haraguchi, and it's a nice classification, but it doesn't go stepwise in progression of severity, and there's no treatment algorithm attached to this. So we felt as if we could maybe improve on this, because we felt that there were several types which were grossly different and should therefore be managed as such. So we took 120 consecutive CT scans to base our classification system on. So this is from our publication in FAI. So you've got your type 1s, which is the PITFL avulsion, your type 2s, which are rotational pelons, and these has two subsets. And the type 3 are your true posterior pelons. So this is how they correlate with other classification systems which have been proposed. So I'll go through each one of these step by step. So the type 1 is your PITFL avulsion. So we can see here a typical inversion injury, and as this happens, the PITFL avulses off the posterolateral corner as well as a rim going across. Now with these injuries, what we found is all of them had a syndesmosis injury. Now 3/4 of those were a full syndesmosis diastasis. The other quarter were just simply posterior syndesmosis, and I'll go on to this later on in the talk on how we determine that. You see on the bottom line is that the majority didn't have medial malleolar medial malleolar fractures as well. So for the type 2, that's a rotational pelon. So here we can see that there is external rotation of the talus, and as this happens, it knocks off the posterolateral corner. And if it rotates further, is that you get an extension, a second fracture line extending across. So that becomes a 2-part posterior fracture. And this was backed up on the CT scans, which showed that there were fragments which were reproducible size and anatomy. So you can see on the left-hand side, you've got the 2A in one part, and on the right-hand side, you've got the 2B, which is in 2 parts. So with these, there is less incidence of diastasis injury, about 1 in 2, and there are more medial malleolar fractures that occur with these. There have been a couple of papers which have shown that if you do need to fix the syndesmosis in these, there is far greater stability if you fix the posterior malleolus as well as dealing with the syndesmosis, and it is also more accurate. So going on to the type 3s now, the type 3 is your true posterior pelon. Now this occurs with a plantar flexed foot with axial loading, and this causes a shear force which shears off a large chunk of the posterior part of the plafond with displacement. And we can see from this schematic that there's a high chance of getting some chondral injury as well. Now with these, we found that the syndesmosis was stable the majority of the time, but that the majority had a medial malleolar fracture, and these tended towards the more complicated types of medial malleolar fractures. And CT is going to be really necessary to determine what metalwork you're going to put in that. So a real take-home message here. So the type 1 is a PTFL avulsion, which will always have some degree of syndesmosis injury, whether that's full syndesmosis or just the posterior part. Your 2A is a rotational pelon, which has got a 1 in 2 chance of syndesmosis injury, but also involves some articular surface. And the type 3 is an axial loaded true posterior pelon, which has got a much higher chance of having a complex medial malleolar fracture, as well as having some chondral injury. So what is our algorithm? Well, the type 1 needs some form of syndesmotic fixation. Type 2A is that posterolateral corner, and that can be fixed from the back via a posterolateral incision. Now for the 2B, which incision is used is either, if it only extends across the posterior surface, a posteromedial incision will suffice. If it extends further medially, going up towards the anterior surface of the tibia, is that you'll need a posterolateral and a medial posteromedial incision. Now that medial posteromedial incision is just behind the medial border of the tibia in front of tibialis posterior. The posteromedial incision is just the medial side of the Achilles, and the posterolateral you can either do just lateral to the Achilles or in between the sural nerve and the peroneals. Your type 3 you can always get to through a posteromedial incision. So how did we determine this? This was another piece of work that we did looking at what could be visualized on the back of the tibia from each one of these incisions. So this was done on at least 10 cadavers, and we did the incision and the exposure, and then put K-wires at the limits of what we could see, and then took radiographs, and then we could perform these schematics to show that for what incisions were necessary for each type of fracture. So how do we go on to treat these? Well, for the type 1 is you can see this rim which has been taken off with PITFL, and that will need syndesmosis fixation. So this one actually had a medial malleolar fracture, so that's been fixed, plus the lateral malleolus in a standard fashion with a syndesmosis screw. Lyndon will go on more about the syndesmosis afterwards. So to show what we mean about the posterior syndesmosis injuries, normally you'd carry out a hook test, or more commonly an external rotation test, to check whether the syndesmosis is intact. Now, if you do this with a posterior syndesmosis injury, you won't see any difference. So there will be no difference on external rotation test. However, if you internally rotate the foot, is that you'll see all the signs of syndesmosis injury with decreased tibio-fibular overlap and an increase in syndesmosis diastasis. So with these injuries, do your external rotation test. If that is normal, you must do your internal rotation test. And here you can see this abnormal test is negated by putting a screw across. So we need to be careful when we place our clamp and when we place a screw that we maintain the accuracy of reduction. So here we can see where clamp's been placed nicely, screw placed across, and that will heal well. If you over tighten it, you'll sublux the fibula posteriorly. And if you really over tighten it, you really can get that out the back and put the screw across the fracture sites. Now you say, well, that's going to be impossible to do. But here's an example from a paper in 2009 from FAI. So going on for treatment of the type 2As, the more minor rotational pilons, is that we fix all of these prone. Now it takes a bit of getting used to fix a medial malleolus and the lateral malleolus, but it quickly becomes second nature. So with these, we're going to want to fix them through a posterolateral incision. So we put them in the prone position with the affected leg elevated so we can see that posterolateral side nicely. And if we need to take out this bump to fix the medial side, so be it. And here you can see a fairly standard posterolateral corner fracture. This has been fixed with some compression screws and a buttress plate. Now there is a full syndesmosis injury and a tightrope has been used in this case. For the type 2B, which is a more major rotational pilon, we want to get to the posteromedial side, or the medial posteromedial, as I said before, so that we can fix this. So they're in a semi-prone, almost like recovery position, with the unaffected leg raised, and this one down on the operating table. And this provides more than adequate access. So the important thing if you're fixing one of the 2Bs is if you fix this lateral corner first, what will tend to happen is as you compress it up is it will squeeze out here and it will squeeze this posteromedial corner out. So you must do the medial side first. To reiterate, you must fix the posteromedial part first and then the posterolateral. So these are fairly typical X-rays and CT carried out. And this has been fixed with two cannulated screws and an anti-glide plate, as well as standard fixation of the other fractures. Now, this one is what I was referring to with the more medial, the more medial fragment. So you can see this double shadow here. Now, this means that the posteromedial fracture is extending around past the median line up towards the anterior surface. And this is backed out on the CT scan where you can see it exiting out here. So for this, the medial posteromedial incision at the medial border of the tibia, just in front of tibialis posterior, and you can stick a buttress plate on that to fix that down nicely, and then fix the rest of the fractures as we said before. And this one actually had a syndesmosis injury, so this one actually got a tightrope as well. So for the type 3s, the true posterior pilons, well, we need to fix those as you would do for an anterior pilon, get them back anatomically. And you can always access these through a posteromedial incision. Now, as I said before, when talking about these type of fractures, you tend to get some more complicated medial malleolar fractures. So we can see quite a lot of comminution at the top, and that there is a vertical shear fracture. So this has been fixed. You fix the posterior parts first, and then we'll fix the medial malleolus afterwards. Now, for all of these, you need to fix the posterior part first, because if you go and fix the fibula, you cannot see the posterior part at all, and it's very difficult to see whether it's reduced or not. So what were our results? So this is the initial study done with Leicester from which was presented at BOFAS in 2016 and has been published. And this showed that there was an average OMAS scores in these fractures of 54. With our treatment algorithm, this has improved to 74. So what this means is that it is now equivalent to a bimalleolar ankle fracture in their outcomes. And that's why we'd highly recommend that you follow this classification system and the treatment algorithm that's been derived from it. So if you split it up into subtypes, is that you see the type 1, 2A, 2B are identical. The type 3, which is the true chondral injuries, are slightly worse, as one would expect. So we're not alone in showing that these posterior malleolar fractures should be fixed. And you can see that there are 8 other papers from level 2 to level 4 showing functional results equivalent to bimalleolar fractures with fragment-specific fixation. So, to summarize, the historical treatment of posterior malleolar fractures resulted in poor outcomes. Size does not matter for treatments, as all of them will require treatment in some way. And CT is necessary to determine the right treatment algorithm, the right approach, and the right type of metalwork to put in. And again, we'd strongly advise that you fix them as per the treatment algorithm. Thank you.
Thank you very much, Andy. That was really interesting and full of lots of gems and pearls, such as remember to do the external rotation test and then the internal rotation test, and all the different approaches to use in fragment-specific injuries. But let's keep the questions which are coming in and keep those to after Lyndon's presentation on the syndesmosis. So over to Professor Mason.
Okay, here we go. Why is that not allowed me to share that? Give me a second. Share screen. There we are. Everyone see that okay? Yeah. So thank you for inviting us both up. So my remit has been the syndesmosis aspect of the ankle fracture. Now, start with a new word for the orthopaedic lexicon, sequacious. It means someone who follows the opinions of others in a slavish and irrational fashion. So I don't intend to divulge a lot of information now that I expect you to follow irrationally. I'm going to try and provide a lot of evidence. And if you, the evidence is usually with a paper on that side of the screen, all right? Or if I haven't done that, I'll hopefully have given you the reference to go back with. I'll hopefully answer all the questions you've got. and may be asked in your exam. So syndesmosis itself has got a lot of evidence. So if you type in syndesmosis and ankle into PubMed, as you can see, is over 1,000 results. I'll go through the anatomy, the diagnosis, reduction, what implant may you use, and then the post-op. So for the anatomy, you've got the joints, ligaments, biomechanics, stability. So to start with the joint, the syndesmosis is a synovial joint. The synovium itself is it's a hyaline cartilage itself is at the anterior aspect of the ankle. That's because of the way it moves. As you can see by this cadaveric specimen, we have hyaline cartilage here, but nothing at the back. At the back, you have the strong ligament, which is a pivot, okay, because it opens by external rotation. We go into that now. The cartilage is only at the bottom 0.5 to 1 centimeter, and the rest of it is the syndesmosis recess. That goes to about 1.5 centimeters above the joint. In regards to the ligaments, so first of all, you have the ARTFL. This is usually somewhere between 3 and 5 bands, and the cadaveric work that we've done ourselves, most of them do have 3. And 60%, this inferior band here, which got number 3 on, do actually attach to your ATFL. If you have a syndesmotic ligament, don't rule out that they have an ATFL injury as well, even with an ankle fracture. The PTFL, you have a deep portion that attached to the posterior malleolus, which you've just heard from Andy. But also this intermalleolar ligament, don't forget this one, and I'll explain why later on. It's a secondary stabilizer of the syndesmosis. As well as the deep portion of the PITFL, you also have a superficial portion. The superficial portion is seen here. This is some work that we did back last year, looking at the anatomy of the PITFL, and you can see it can go all the way across the back of the tibia. There's some other cadaveric specimens, not from ours. I think these ones are Sesks from London. And the one thing I want you to draw attention to, the interosseous membrane, and this aperture within the interosseous membrane is where the perforating artery from the perineal comes through, and I will come back to that later. Biomechanics wise, so the fibula itself, it everts and it externally rotates as you go through your the motion. Now this is one of Karen's paper, who's also one of the panelists today, that when they weight bear, the fibula also rotates out. So this is a comparison between a non-weight bearing CT and a weight bearing CT. And as you can see, the posterior aspect stays a constant length, but the anterior aspect rotates out. Stability wise, ARTFL is the most important rotatory stabilizer. This paper has gone and cut it from front to back and then from back to front, and found that the ARTFL, when they start cutting from the front, give you the more stable on rotation. In regards to coronal stability, this only actually made a difference when all the ligaments were gone. So that's the coronal stability is the translation. We'll come back to that when we're talking about the hook test and the external rotation test later on. Sagittal stability, you don't need much in the way of ligament injury to actually have sagittal stability. And sagittal instability is from back to front, so the movement of the fibula from back to front. So if you talk about, well, does the bones make a difference? We talk about the ligaments. The incisura is actually a very shallow cup, so it doesn't really give you much bony stability. This is a paper I've already mentioned with the average surface area type 2B fracture. If you look here, the type 2B, which is the larger bony injury, actually had less syndesmotic instability. And the reason for that is the average area of the PITFL covers the entire back of the tibia, which is much greater than the 2B fracture. So if you have a mainly bony injury, the ligaments are sometimes reserved. But if you do have an injury to the syndesmosis and the posterior malleolus, actually fixing it will give you better stability. And there's 5 papers indicating this. This is another one of our papers looking at the intermalleolar ligament avulsions with the posterior malleolus. And this is what you get. This is the intermalleolar ligament. And in pronation injuries, as the fibula moves in that direction, it does pull off a bit this fragment. So you can see this fragment here. This is some work we've done that we haven't published yet. It was presented in BOFAS last year. That the Wagstaff, which is the footprint of your AITFL, if you have a look at it and compare it to dissection, when we had a look at all our CT scans with a Wagstaff fragment, which is only with 40 of them, they average about 10 millimeters, and the size of the ligament is 21. And only half of them had ligament instability. So if you do have a Wagstaff fracture, it doesn't mean your syndesmosis is unstable. But if it is unstable and you fix that back, you will repair some of that ligament. The diagnosis. So clinically, well, it's difficult with an ankle fracture because it's usually very swollen and very painful all over. But I put these in just for the completion sake. If you get a dorsiflexion external rotation test, it's by far the most sensitive and specific. As you can see, as you're coming down this on this paper, the local tenderness and the squeeze test are either sensitive or specific. But if you add them all in together, you get a much better result, both sensitivity and specificity. There are other examinations, such as a cross-leg test or the ballottable syndesmosis. Radiographic, Andy's already commented on this as the tibio-fibula clear space, which is from A to B, and your tibio-fibula overlap, which is from B to C. As you can see, this is usually less than 6 millimeters, greater than 6 millimeters, and on your mortise view, this goes down to greater than 1 millimeter. But it's very variable. There are papers that show that if you look at the entire population, it is a normal distributed. So you have people who have much wider syndesmosis, which is normal. It's very important to actually x-ray the other side if you've got any concern. This is just to demonstrate on what was a schematic, what it looks like on an x-ray. Intraoperatively, the ones most people know is the hook test and the external rotation test. Now, as you can see, the hook test has a sensitivity of only 25 as compared to the external rotation test of 58. But as I said earlier in regards to stability, for the hook test to work, you have to have 3 ligaments gone. So it would have to be chronally unstable. For external rotation test, you only need 1 ligament to be gone to be rotationally unstable. So the external rotation test, for me, in my practice, is what I use. So as you can see, this is an external rotation test, opening up, it's the medial opening and opening of the tibio-fibula clear space. I won't labor on this. It's also the internal rotation test that Andy's already been through. You can do arthroscopy, and this is in a lot of papers seen as the gold standard for testing of syndesmosis. Personally, I went through a period where I scoped all major nerves. I must say I didn't, in my hands, found it not very usable, but there's plenty of centers that use it with great success. As this paper shows that what you're looking for the syndesmotic reduction, you can see AITFL here, and so there's a gap, and there's the fibula to show that you've got posterior translation, and we've got overlap of PITFL. That's why the fibula has been posterior translated. Reduction. So we're going to go through the assessment, how we use the clamp, and other influences. So assessment. So if you're assessing your syndesmosis reduction, you're either assessing it clinically or radiologically. Clinically, the 2 tests are either to look at it. And this is one you can see as we are looking, and you can see where the fibula, the AITFL tubercle sits underneath where your AITFL footprint, the tibia is, but you can also palpate it. Personally, I usually palpate, and this paper has shown no difference in malreduction, even you palpate or you have a view of it. We've already been through what you're looking for on your AP, but on the lateral, you're looking for the fibula to have an intersection with the posterior plafond, as you can see. Okay. On this paper, only 6% had anterior translation greater than 2 millimeters, so we expect it to be coming through the posterior plafond. How you apply the clamp, there's 2 good papers on this. This is one of them, where if you predictably put your clamp in between the anterior aspect of the fibula and anterior aspect of the tibia around this region, then this is the perfect area to get a central reduction. This paper actually went further to look at malreductions. You can see there is no malreductions anteriorly displaced if it was on the anterior tibia, and there's only very few on the posteriorly displaced on this area. So this is where you're looking for, around this area here. And this is also where you're looking to put your screw. Other influences. So if you have any slope, anterior, posterior, and you put a clamp on, then it will move in that direction. Now, you're not going to know that unless you've got a CT beforehand, which is not really routine for all syndesmotic injuries. The other one is, as we could return again and again to the posterior malleolar fracture. If you have a big posterior malleolar fracture and there's a gap, so not only so if this is moved this way or this way, if there's a gap in between, you will have a gap malreduction. So if you're not fixing these and you just put in a clamp on, especially if they're large, you are a better person than I to get a perfect reduction on these. And Andy's already alluded to this, and you can see this, if you see the posterior malleolar fracture, so well off like this, the syndesmosis is definitely malreduced. And you can see the fibula itself is also sitting not in line with your posterior plafond. So you can know that that fibula is malreduced. And he's already done this. Can you over compress the joint? The answer is yes. I've done this twice, where when you put in the syndesmotic fixation, it spits out your saddle-shaped talus. And this can only happen really if ATFL and deltoid are also damaged. But that can happen. It's happened to me twice, and you put the syndesmotic fixation in and it actually moves forward. This is not one of mine, this is from a different paper. And as you can see, as they removed and revised it, the talus is now sitting in the right position. What implant do you use? So this was a paper from FAI many years ago, and you can see when they asked all the different questions, there was a raft of different answers. Do you position the live screw diastasis screw was relatively on position, and I agree with that. Do you elect to remove the screw? And after, this was over 10 years ago, and they said mostly yes, but we'll go through why, and so I don't elect to remove mine. What screws? Well, number of screws, number of cortices, size of screw, position of screw. On the cadaveric, radiological, and clinical studies, there's no difference. Okay, this review paper, there's another review paper by James Calder as well, all saying the same thing. There's no difference no matter what you use. Hardware placement. Well, we've already said that the syndesmotic recess is 1.5 centimeters from the joint, and 2 centimeters above the joint is the ideal strength maintenance. That's where you want to keep it for the strongest hold. But also remember, as I talked to you about that area of where the perineal artery perforated comes through, as you can see, it's coming through here, coming through to the front, to the back of the syndesmosis of the perineal artery, and the perforate is coming through the front. And it supplies 60% of your anterior ligaments. And also, if you catch it, it's a relatively large artery to actually injure. This is on average 3 centimeters proximal to the joint. This is another one where they looked at the, in comparison to screws, superior and inferior, and you can see the inferior screw is usually well away from it, but the superior screw can be very close. So in theory, you need to get your implant somewhere between 1 centimeter and 3 centimeters from the joint. Hardware choice. So this is the question between suture button or screw. So cadaverically, a suture button provides a lot less strength than a screw fixation. However, if you compare it to normal walking in a boot or plaster, the 20 nanometers that it requires for this, it doesn't actually reach that point. There's a level 1 meta-analysis come out this year, 7 level 1 RCTs. There's been 1 RCT published after, I'll say that later. And they found that intraoperative inadequate reduction was much more improved by your dynamic fixation. Follow-up inadequate reduction, again, much more in favor of the dynamic fixation over screw fixation. Clinically relevant complications, again, much more in favor of the dynamic fixation. Reoperations, even if you take out the ones that were planned reoperations, again, more commonly in your dynamic fixation did better. The AFAS functional outcomes were much better at every time point. OMAS strangely weren't, but it was close to it. But with the addition of the most recent RCT, that would probably go much again to dynamic fixation. and dorsiflexion, you achieved about 4 degrees greater. This is the most recent paper published in BJJ this year. 5-year outcomes, and no mass are significant throughout. So it's much, gives you much better outcomes with a tightrope or a suture pressure fixation as you do for a single screw. But there are times that you can use it and times you can't. So this middle question here is the important one really. Is the fibula length actually stable? So if you fixed it with a plate and then it can't move up and down, so then you can usually use it for rotational stability. However, if you don't fix it, so then it can move up and down and side to side and chronally unstable, then the syndesmosis fixation, as I said with the cadaveric study, is a lot less stable. So this is in keeping, this is not one of mine, it's from the International Orthopaedic Journal, which is a good example. You can see that they fixed it even though it was a high fracture, and they're rotationally stable with this tightrope. However, if you've got a posterior malleolus fracture like this one, you can actually fix this fragment back to get your length stability, even with a Mason nerve fracture, and then put a syndesmotic fixation across. And Andy had a few examples on his cases on that. It's another example. Ankle in position implant insertion. I was trained that you had to really maximally dorsiflex, otherwise you over tightened it. There's 2 cadaveric papers that show there's no difference regardless of ankle range of motion. These are both them 2 papers. So other risks, if you're going straight across your 20 degrees, so coming out the anterior aspect, 10 to 25 degrees is where your saphenous neurovascular bundle are. So if you're putting a suture button there, you have to be very careful. Post-surgery, go through screw removal and weight bearing. So screw removal, there's some people who believe that you have to take the syndesmotic screw out before you start weight bearing. Now that's something, quite an early time to commit someone to another surgery following an ankle fracture and not allow them to weight bear beforehand. This study, be it that it wasn't a level 1 study, but it didn't show any significant difference in clinical outcome if they removed or not. Unrelated to clinical progress, recurrence of diastasis was found if you did remove the screw, however. Removal of screw dorsiflexion, no improvement in dorsiflexion if you remove the screw. Removal of screw and function, so there's 7 studies, there's 1 RCT within that. And no improvement in functional outcomes, no improvement in radiological outcomes. And some actually studies found that if you retained the screw when it broke, they actually did the best. And you were looking at somewhere between a 10 and 30% syndesmotic screw break-in if it's left in. However, if you do have a malreduction, which this paper said that if they CT'd everyone at 3 months, there was a 30% malreduction rate. And they removed, CT'd at 2 weeks, and they removed them at 3 months. It actually reverted back to a normal reduction in 90%. So if it is malreduced, then removing it can make that better. Complications of screw removal. So this paper showed that there was up to 10% had wound infections afterwards, which 3% had a deep infection, and also recurrent syndesmotic diastasis in 5 to 10%. They found that, I thought this was a pretty good graph that they showed that if you took it out even too early, that's when you had your diastasis. Weight bearing. So there's 2 papers that show that weight bearing from 2 weeks do fine. So if you weight bear your syndesmotic fixation, they all progress to union, no hardware failures. And this one, no difference in radiographic outcomes if they weight bared compared to if they didn't. So to summarize, knowledge of anatomy is very important. Think of the coronal and rotational instability. Flexible fixation where possible. Remove a screw, not necessary. And weight bearing early does seem safe. We'll know a lot more of that when the wax trial gets published. Thank you.
Thank you very much, Lyndon. Hopefully we can be joined again by Andy. And hopefully we have all 3 pictures maybe. We've got some time for some questions. We've had a couple of questions. I like the way you described the approaches, Andy, for the types 1, 2 and 3, with the type 2 and 3 predominantly being prone, posterior medial, posterior lateral approaches. Does that mean that most of the type 1s are supine?
Yeah, so for a type 1, essentially, you're carrying out syndesmosis fixation and fixating the lateral and medial malleolus if present. So they can just be fixed as you would standardly an ankle, just supine, maybe a sandbag under the ipsilateral buttock.
And the question from the audience was, can you also do that one in a prone position if you wanted to do all of them prone?
Yeah, if you wanted to do all of them prone, you could do. I think the only difference in the prone position is if you're going to do a posterolateral incision, is that you want to have that leg, the affected leg, elevated so that you can get to that lateral side easier. If it's going to be a posteromedial incision, is that you need to have the unaffected leg elevated so you can get to the medial side. But one of the easiest ways to do that is if you have some of the foam blocks, just wrap them in a Mayo bag and then you can change position and raise the legs up, or if you're able to have a split leg table.
Thank you. And Matt Philpott has got an eye for detail. He wanted to ask you the question about how do you tell the difference between a large type 1, which extends across the back, and a small type 2B?
It's a very kind question from one of our contributors. I'll hand that to Lyndon, did you want to answer that?
Yeah, so it's just due to the type 3. You said type 1 or type 3, did you say? Sorry,
no, type 1 or type 2B.
Okay.
Versus 2B.
Yeah, it's very difficult to do so in truth. But usually the type 2B, you'll have its articular involvement. So your type 1 is all extra-articular. Your type 2B is intra-articular.
The other thing that we found with the type 2B is that the secondary fracture line goes in a relatively predictable direction, which you won't get with a type 1, is that you'll tend to have quite a lot of comminution as it goes across. And the other simplistic way of thinking about it is it big enough to fix? If it's not big enough to fix, it's a type 1.
Okay. And obviously a lot of the damage to the cartilage occurs when the fracture and that occurs with the subluxation, and there are forces across the cartilage. With your studies, which of the 3 patterns had the most subluxation?
The type 3s. Type 3s are usually all the way out.
So, and did you have a chance to look at the damage to the cartilage and MRI studies or intraoperative opinions?
No, so getting a scope in posteriorly is pretty difficult. You can do it, but it is difficult. One of the reviewers, when we sent it into the JBGS, asked us that we should have scoped them all. It's just something that we don't have readily accessible in our trauma theatre, in truth. I know Hintman was scoping all his ankle fractures, but it adds another level of complexity to it, I think.
I think especially as the prone, to do a posterior ankle scope so that you could do something with it would be very difficult. If there's a big osteochondral fracture, you'll see that on the CT scan that you get beforehand, and sometimes you can peel open the fracture sites as you would do for a more standard anterior peel on and take that out. But I think as yet that's something that we haven't specifically addressed unless there was a large osteochondral fracture.
So we're just talking about arthroscopy, which has relevance also to assessing the syndesmosis. You tried a little bit of arthroscopy in the acute ankle fracture to look at the syndesmosis stability. How much movement of the fibula do you have to decide there is a syndesmosis injury, in your opinion?
It's, in my opinion, so in the acute phase, you can, with the Mason nerve, it's pretty easy because you can quite clearly see it beforehand. I have not done ankle arthroscopy on the less obvious, but for the obvious Mason nerves, you can get your 4mm scope all the way up.
I think that's a fairly good rule of thumb, is if you can fit one of the trocars into the syndesmosis, that is abnormal. And I think if you carry out your rotation test when you've got the scope in there, you just need to be careful that you don't see anterior gapping of more than 2 millimeters. James Calder's paper on that in the British Journal is very good.
And we were talking about the tightropes. You said that a single tightrope, one of the problems is it may not control the length stability and perhaps rotational stability. What about the use of 2 tightropes? Does that give you better control?
So I've had a few tertiary referrals with them 2 tightropes failing in that way, where the fibula just shortens on it. I think it gives you really good rotational control and coronal stability. It doesn't give you axial stability. But there's no study. That's just anecdotal. Just what I've seen come through. It's not something I do, but it's something I've had coming through for second opinions.
And we've got time for just a couple more questions, really. So when you're on the operating table and all you have is your 2-dimensional X-ray, you just recap again how you decide whether the syndesmosis is back into the correct position when you reduce the fibula properly.
So first of all, I would palpate it. So you have to come over the top of the fibula. I don't feel personally, so I've gone away from relying 100% on your radiographic parameters. But if you are, then you looking at your tibiofibular overlap, your clear space, your medial clear space, and then on your lateral, you're looking at the posterior aspect should usually intersect with the posterior plafond. And if you've got any other issues, then check the other side. So the majority will have similar views on the other side.
Okay, well, we're running towards the end of our hour. So I have a question from Alistair Robertson about what's the role, or does anybody use intraoperative arthrograms to assess the syndesmosis?
Yeah, so I don't. I've tried it. I tried it a few times, but I feel if you got a flap, if the ones that it goes all the way up, you'll know that they are syndesmotic damage anyway. And those ones which you're suspicious of, you can have a flap of tissues when you scope them in the way anyway, which can stop that arthrogram being successful. So you can have quite a few false negatives with it. And
then a question about quality control and how we assess how good we are and how we audit our results from Niraj Purohit. Should we be, we've agreed, I think, and we've proposed that people should do pre-operative CTs. Should we be doing post-operative CTs so we can get better at fixing these posterior malleolar fractures?
So, I mean, we initially did with ours in getting CTs because although if you fix the posterior fragment first, is you usually can see that quite nicely, but also you do have some direct visualization of it. But the normal mistake in doing it is that you haven't depressed the posterior parts enough. So it's a bit like akin to if you're doing a DHS, where you think your guide wire is going to be in, it's going to be below where that is because otherwise it's too high. So if you think you've got the fragment down in the correct position, try and depress it another couple of millimeters and then you get an X-ray. So we initially did CT scans, but we found that they were all reduced. So we stopped that because we couldn't justify the radiation exposure.
Okay, and just a final question then from Turab Saeed in Scotland. Have you considered removing syndesmosis screws in high demand, say perhaps professional sportsmen, and replacing them with tight ropes to maintain some dynamic stability when they return to play?
So the obvious answer initially would be, why did you put a screw in first if you wanted to put a tight rope in? But if you'd already had a screw in or someone else put a screw in and you want to put it in, then hopefully you'd be removing it and not have to put a tight rope in. So you leave it long enough.
Okay, but sometimes I imagine the direction of the question, sometimes they want to return to play and may not want to break the screws. But unfortunately, we're getting close to the hour. We had some interesting cases to discuss, which we'll have to leave aside. There will be other ankle fracture sessions in this series, which is going to be approximately 30 weeks long. I'd just like to remind the attendees, and we had 239 attendees this evening, that you'll be approached for feedback tomorrow. If you successfully and complete all your feedback, then after 4 weeks, we'll be sending out attendance certificates for CPD. We'll be doing that in batches as this 30-week program rolls out. This evening's webinar has been recorded, and this should be up on the BOFAS website tomorrow. And that leaves me really to just remind you, next week we have the talk is on the Wednesday. We're deliberately rolling this through the different days of the week so that different people's timetables and on-calls allows them to join as many as possible. And next week it'll be Steve Heppel from Bristol talking about early ankle arthritis. So finally, I'm sure you're all standing up from your chairs and clapping loudly and thanking Lyndon and Andy for their contributions of bringing science to the two difficult areas of ankle fractures, the posterior malleolus and the syndesmosis. Thank you for attending.
Thanks.
Thank you very much.